I'm Dr. Keshav Malhotra. I'm the director of Rainbow IVF Agra. I'm also the director of Malhotra Embryology Training Academy. I'm currently the co-chair of SIG Embryology for Aspire and the second vice chair of embryology for the Indian Society of Assisted Reproduction. Today we are going to be discussing a very interesting topic, a very important topic for all of you, and that is monitoring laboratory performance through key performance indicators. Now, before we begin this, we really have to understand what we mean by key performance indicators. Now, key performance indicators are basically quantitative as well as qualitative assessment of data that you have in your laboratory. And this is something that we can use in order to actually compare our performance in the laboratory. That's pretty much it. So these are tools which can be used to make decisions, and these are tools that can also be used to actually control the kind of work that's happening in the laboratory. When we talk about key performance indicators, whenever we're thinking of measuring them, we have to look at the type of key performance indicators. And the first thing that we have to understand is that they have to be smart. Now, what do I mean by smart? So smart basically means they have to be specific, they have to be measurable, they have to be aligned to the kind of work that you're doing, they have to be reliable, and they also have to be done timely. So if you're following these 5 basic principles of trying to tabulate key performance indicators in your laboratory, I think you'll be able to actually monitor your performance quite well. Through this lecture today, basically what we are trying to aim for is to actually list out all the key performance indicators that we have for embryology laboratories. We also want to try and basically discuss the minimum levels and the benchmarks that are available for embryologists. And we also want to come to some sort of a consensus on what is the minimum number of KPIs that a laboratory should actually be using on a daily practice. So when we talk about key performance indicators, the publication that comes to mind is basically the Vienna Consensus. So in 2017, ESHRE as well as Alpha actually came up together and came to a consensus and released about 19 performance indicators, which included 12 key performance indicators, 5 performance indicators, and 2 reference indicators for the laboratory. Now, what do I mean by reference indicators, performance indicators, and key performance indicators? So basically, when we talk about reference indicators, these are related to all the eggs that are coming into the laboratory. So anything which relates to the quality of the oocyte, we are going to basically assess it through a reference indicator. When we talk about performance indicators, it basically is all the data that should be documented within your laboratory. It's not necessarily that you're going to really assess this data on a day-to-day basis, but this is something that you would want to document within your laboratory and store this data for later use. And when we talk about key performance indicators, now this is the core business of an ART laboratory. Now without these key performance indicators, which are 12 in number, any laboratory would not be able to monitor the quality of its performance. And that's something that each and every lab director should actually ensure that their lab is following. So coming to the reference indicators, now like I mentioned, there are 2 reference indicators. The first is the proportion of oocytes that are recovered, and the second is the proportion of M2 oocytes that we get in the laboratory. So when I talk about the definition of the first reference indicator, which is the proportion of oocytes recovered, is basically calculated as the number of oocytes that are recovered divided by the number of follicles that are there on the day of trigger, and you multiply it by 100 to get a percentage. Now, important to understand here is that the follicle size that you're wanting to consider here is about 14 mm. So you're going to count basically all follicles above 14 mm and use it in this calculation, and then obviously you're going to calculate the number of oocytes that you've recovered and come to a percentage. Now what does this indicator tell? So it's basically talking to me about the kind of stimulation that I'm using in my laboratory, and it's also giving me a little bit of insight into the performance of the clinician. So let's say I have 4 or 5 clinicians working in the laboratory, and this reference indicator is varying amongst the clinicians, whereas the stimulation is standardized for the clinic. Then I can basically assess the clinician that who's not recovering the most amount of oocytes, or is recovering the least amount of oocytes, can actually be trained a little bit more. And this basically, as a lab director, this tells me that that is the person that I want to train and check off for the specific procedure. Now the second one is the maturation rate, or the number of M2 oocytes that you recover. So basically this is the number of M2 oocytes divided by the total number of eggs that were recovered, and you multiply it by 100 to get a percentage. Now what does maturation rate tell me? Again, it's talking to me about the stimulation protocol. Now let's say my maturation rate is going down and I want to assess why it's going down. So this is what I will do, is that I will basically take the patients who have a low maturation rate. I will look at their number of days of stimulation first, and most likely I would probably understand here, like I'm just giving you a scenario here. When I compare it to my own laboratory, I've seen this in my lab, that whenever maturation rate has gone down, most of the times it's an early trigger, maybe a day 9 trigger. So that's something that we can rectify later on. Or as common practice, you can establish that, okay, in your laboratory you're going to have a 10-day stimulation or a day 10 trigger for your patients. So that's something that you can basically do for your lab if you're not monitoring the cycles routinely using ultrasound. But generally clinicians do monitor this, and whenever they are comfortable with giving a trigger, or whenever the dominant follicle is about 20 or 21 mm, they would generally give the trigger, and it could be on day 9 or on day 10. Another thing that it's telling me about is the quality of the trigger that I'm giving. So let's say the maturation rate has gone completely down. So what I'll do is I will check the lot number of the HCG injection that has been given to these patients, and then try and troubleshoot accordingly whether that particular injection or that particular lot is responsible for the decrease in the maturation rate. Another thing that can happen with this particular rate is that the clinician who's doing the procedure might be aspirating all the smaller follicles as well. And generally smaller follicles which are less than 14 mm in size might give us more immature eggs. So that could also be a reason why we are getting a lower maturation rate within our clinic. So these are the kind of information or like kind of points that you can actually derive from these reference indicators. Very, very useful. I find it very useful to monitor clinical parameters, and hopefully with this knowledge you might also be able to assess it within your laboratories. Now coming to the next part of this lecture, and that's the performance indicators. So like I mentioned, we have about 5 performance indicators that we want to assess. Now it's already been established that these are things that we would not probably like monitor on a day-to-day basis, but we would want to document it and we want to store it for later use. So what are these 5 performance indicators? So the first one is basically sperm preparation motility, or sperm motility after preparation. And generally we are wanting to see to basically have a competency of about 90% and a benchmark of about 95%. Now what does this tell me about my embryologists or androtechnicians in the laboratory? So let's say the sperm motility after sperm prep has gone down to 80 or 85 or even 70%. So it's either telling me that the type of sperm preparation technique that has been used for that particular patient is not correct. It is also telling me that maybe the technique of sperm preparation has gone wrong. And a small example of this could be that when you're taking out the final pellet, you've left out some of the residue, and that has contributed to increasing the number of dead sperms within that pellet. So that could be a small example of that. And it's also sometimes telling me about the skill of the androtechnicians. It can also tell me about the quality of samples that I'm getting in the laboratory. It can tell me about, let's say if I'm exposing the sample for too long before sperm preparation or even after sperm preparation during the time that I tabulate this. All of these things can also influence the percentage motility after sperm preparation. So this is something that we have to assess, and if this goes down, what can get compromised? My IUI results can get compromised 100%. IVF also results can get compromised, and with ICSI I might get lesser motile sperms than I might get when I've done a sperm preparation properly. So these are certain things that we can assess using the first performance indicator, which is sperm motility after preparation. The second one is basically polyspermy rate. Now polyspermy is something which people generally don't calculate. It's easy to calculate. How do we do it? We just take the number of multi-PNs that have been formed after IVF divided by the number of COCs that were inseminated, and you multiply it by 100. And if the polyspermy rate is less than 6%, that is the benchmark that we want to achieve in our laboratory. Now, when does polyspermy increase? So, if I'm getting more than 6% polyspermy, first thing that I have to basically check is the amount of sperms that we are putting into the droplet. So that will be 1. Second is the total duration that the sperms are exposed to with the egg. Now generally I follow a short insemination protocol, which basically means that I'm removing the egg from the sperm source within 4 to 6 hours. But a lot of people still do conventional IVF. That is that they will expose it for about 16 to 18 hours, and that can increase the incidence of polyspermy within the clinic. So that's something that we would want to establish, and if it's going high, it's basically telling us that we want to calculate the amount of sperms that we want to inseminate and then only do the IVF insemination in the laboratory. The third rate that we are wanting to assess is 1PN rate, and 1PN rate is there for IVF as well as for ICSI. So this is number 3 and number 4. And generally with IVF I want to achieve less than 5%, and with ICSI I want to achieve less than 3% 1PN rate. It's again telling me about the quality of the sample, it's telling me about the quality of the eggs, it's also telling me about the skill of the embryologist. Sometimes exposure can affect the PN formation. So it's telling me about the environment that the eggs are fertilized in. So all of these important factors I can assess using this particular rate. And the last thing that I personally find very useful is good quality blastocyst formation. And the general competency that has been established for good quality blastocysts on day 5 is 30%, and the benchmark that you would want to achieve is about 40%. Now, why is this rate important? Because it's these good quality blastocysts that are generally going to be transferred or are going to be cryopreserved preserved. All the others, let's say you're getting a very high blastulation rate, but the good quality blastulation is low. Let's say I have a 50% blastulation rate, but only a 15% good quality blastocyst rate. It actually tells me that even though I have the potential to culture till blastocysts, my culture conditions are not adequate. That is, I'm not getting the desired quality, and the patients might benefit if I change the culture systems, or I change the culture media, or I rectify some of the important things that can actually influence the embryo quality within the laboratory. So that's one of the important rates from the performance indicators, which I feel, and I necessarily actually calculate this on a routine basis in my laboratory. Now, coming to the list of 12 key performance indicators for the ART laboratory. Now, I'm sure all of you have seen this list, and I think all of you must be following this list in your laboratories, because this has been there for the last 5 years now, and without this, monitoring the performance of the laboratory is actually, you can't do it without this. So anyone who's interested in quality control and quality management, I'm sure they're monitoring these KPIs. So what are they? I'll start with the KPIs for ICSI. So the first KPI that we want to assess is the ICSI damage rate. Now, how is damage rate calculated? It's the total number of eggs that are damaged or degenerated after ICSI divided by the total number of M2 eggs that were injected multiplied by 100. Now, to achieve a competency value here, we want to keep the damage rate less than 10%. But the benchmark that the embryologist would want to achieve here is about 5%. Now, what happens when this damage rate goes up? Now, how do we troubleshoot it, or what are the different things that we would want to consider once the ICSI damage rate is going up? So the first thing that I want to see, I would not start with blaming the embryologist, because there are a lot of factors that can actually influence the quality of the egg itself and the quality of the insemination itself. So we will start with assessing those factors first. So the first thing that I would want to look at is the quality of the M2 egg that was there in the laboratory. The second thing that I want to look at is the type of injecting needle that we are using The third thing that we are going to assess is the skill of the embryologist, the experience of the embryologist. Because let's say you have an experienced embryologist and still the damage rate is going above 10%, then I'm not really worried about the skill that much, but I would be worried about the quality of the oocyte. But if you reverse the scenario, let's say it's a junior embryologist and the embryologist has just started performing ICSI and that embryologist has a damage rate of more than 10%. In those scenarios, I will ask the embryologist to get trained a little bit more, maybe do supervised ICSI for at least 30 to 40 cases, and then only check that embryologist off for doing individual ICSIs. So this is the importance of assessing the ICSI damage rate. The second thing that we want to assess, or the second KPI that we want to assess, is the ICSI fertilization rate. So this is the number of 2PNs that form after ICSI divided by the number of M2s that were injected, and you multiply it by 100 to get a percentage. And the competency value that we want to achieve here is 65%, which I personally feel is quite low, but that's the competency that any junior embryologist wants to achieve when they're starting. The benchmark that you would want to achieve is about 80%. Generally, when we're doing ICSI, we would want to actually have more than 80% fertilization rate, and this tells us that at least we are doing the procedure properly, we are selecting the sperms correctly, we are injecting the eggs in the right manner, we are not exposing them to temperature changes or pH fluctuations for a longer duration, and it generally tells us about the competency of the embryologist as such. So, and it's not just with the ICSI procedure, but with all the other important factors that can influence the procedure itself. So that is what we will decipher from the fertilization rate with ICSI. We also have fertilization rate with IVF, and that's the third KPI that we are assessing. And again, when I'm talking about competency here, now with IVF we know that the fertilization rate might be a little lower. Now this decrease in fertilization rate could be because we are not looking at the number of M2s that are there while inseminating, because we can't really assess the maturity because we're using a COC, and that could be contributing to the decrease in fertilization rate. So looking at all of these factors, the competency value is about 60% and the benchmark value is about 75% for IVF. Now when IVF fertilization rate goes down, now again the things that I would want to check here would be the quality of the culture media that I'm using, the quality of the sample that I'm using, how the sample was prepared, what was the sperm motility post preparation. That was a performance indicator that we were assessing, and again, how long am I exposing the eggs within that particular sample. Okay, coming to the next indicator, and that is cleavage rate. Now this is an important indicator because this is one indicator where the competency and benchmark is quite high. We would want to achieve a competency of about 95% and a benchmark of about 99%. Now what does cleavage rate mean? So it's basically the number of zygotes that have cleaved into an embryo divided by the number of PNs that were there, and you multiply it by 100. So let's say I've injected 10 eggs and all 10 of them fertilize, but only 8 of them cleave. So the cleavage rate automatically becomes 8 divided by 10, which comes to about 80%. Now why is cleavage rate so important? And why are the standards so high? Because if you're assessing the quality of the zygote and you've correctly identified the PN, it should generally form an embryo if the culture conditions are conducive. So if the zygotes are not forming embryos or are not cleaving, the first thing that I want to check is whether the embryologist is assessing the PN properly or not. The second thing that I want to assess here is, what are my culture conditions like? Is it because of the culture conditions that the embryos are not cleaving, or is there some fluctuation with temperature, pH, osmolality, etc. that the embryos are not cleaving? These are important cardinal factors that I want to assess if the cleavage rate goes below 95%. Okay, now talking about cleavage rate, the next two indicators are basically day 2 development rate and day 3 development rate. Now here what we are assessing is, for day 2 we are assessing the number of 4 cells that are forming on day 2. For day 3, we are assessing the number of 8 cells that are forming. And again, these are important because these are the exact time points, and like on day 2 you are expecting a 4 cell, and on day 3 you are expecting an 8 cell for it to be following the exact morphokinetic parameters. And if you're not getting that, the embryos are generally going to be classified as slow growing embryos. So the competency that we want to achieve for day 2 is about 50%. The competency that we want to achieve for day 3 is 45%. And the benchmarks that we want to achieve is about 80% and 70% respectively. Now, what happens when this rate falls? So firstly, we have to understand that slow growing embryos might not be the best for your patients. They might still develop to blastocysts, but they might not give us the best quality results. And the first thing, and probably the most important thing that we want to assess here, is whether those 3 important cardinal parameters that I spoke to you about, temperature, pH and osmolality, are disturbed or not. Other things that I would want to consider here is the exposure time, the air quality within the laboratory, let's say the VOC content is higher, etc. These are important things that I would assess if my day 2 development rate or my day 3 development rate is going haywire. Coming to the next parameter, and that is blastocyst development rate. So this is basically the number of blastocysts that are developing on day 5, irrespective of the quality, divided by the total number of fertilized eggs multiplied by 100. And we want to generally achieve a 40% blastulation rate within the clinic, but a benchmark that I would want to set, or maybe a benchmark that we would want to follow, is about 60%. So any laboratory which is getting, let's say, 60% blastulation would be confident in offering blastocyst culture for most of their patients, irrespective of the number of eggs that they are getting. And let's say you want to make a decision about which patient to categorize for a blastocyst transfer. In those scenarios, let's say you have 4 good quality day 3 embryos, you would be confident in doing a blastocyst transfer for that particular patient. The next few are basically depending on the implantation. So we would want to calculate the implantation rate for cleavage stage embryos, and we would also want to calculate the implantation rate for blastocysts. Now, generally the competency value for implantation rate is 25% for cleavage stage and 35% for blastocysts. But the benchmark that we want to achieve is 35% for cleavage and about 60% for blastocysts. Okay, so what information do we get out of implantation rate? I think this is the most important key performance indicator in the laboratory, because it's telling us about how the lab is performing, it's telling us about how the embryologist is performing, and it's also telling us about how the clinician is performing. So let's talk about the lab first. So if your implantation rate is good, that generally means that the culture conditions are adequate, the air quality is conducive, and you have a laboratory where you can get good quality embryos within, and you can have a good quality selection for your embryos. What does it tell us about the embryologist? So if the implantation rate is good, it's telling us that the embryologist is selecting the right embryos for transfer. What does it tell us about the clinician? It's telling us that the clinician is following the right protocols, especially for luteal support, etc., and the pregnancy is being established because of that. Okay, but what happens when this rate goes down? So there are certain scenarios that can happen. So the first scenario that I want to discuss with you is, let's say you have a high clinical pregnancy rate but a low implantation rate. So this basically tells me that you are basically selecting or transferring more embryos, and that is what is causing a decrease in the implantation rate. Because if you end up with the definition of implantation rate, it's basically the number of G-sacs that are seen divided by the total number of embryos that were transferred. So let's say I get only 1 G-sac, but I've transferred 3 embryos. The implantation rate is about 33% in that particular scenario. But my clinical pregnancy rate is going to be higher. Now what this tells me is that the embryologist can basically improve upon the embryo selection and reduce the number of embryos that are being transferred in that patient, but still achieve the same clinical pregnancy rate in that particular scenario. For blastocysts, it's even more important, because When we get a low implantation rate with blastocysts, we are generally worried about the quality of the air within the laboratory, because you now have a blastocyst, it's at the right stage of development, it is ready for implantation, but even if it's not implanting, then maybe there are certain hidden factors that are affecting the implantation, and VOCs are one important factors to consider. Second could be the assessment of the blastocyst itself, whether, let's say, the grading has not been measured accurately. The third could be the transfer technique itself, because if it's a traumatic transfer, that ultimately is going to reduce the implantation rate. And finally, if the clinician has not maintained the right protocols post-transfer, or the patient has not taken the medicines post-transfer, then that also can influence the implantation rate. Sometimes it can also tell us about patients who might suffer from endometrial receptivity issues. Maybe they are the category of patients where implantation rate is falling, and in the other category of patients you're getting a high implantation rate. So you can then categorize those patients and do other diagnostic tests in order to actually ensure that you're transferring the embryo at the right time point. The last key performance indicator, or actually the second last key performance indicator, is the cryosurvival rate, and this generally we want to have a competency of 90%, but as a benchmark I would probably say that 99% is what most clinics now strive for. This basically tells us about the skill of the embryologist who's performing the procedure, because most of the times cryosurvival is completely dependent on the skill and the SOP that the embryologist is using. It sometimes might also tell us about the quality of the embryos that are being frozen, because if you're, let's say, freezing a grade 2 embryo or a grade 3 embryo, you can't really expect a very high cryosurvival rate in that particular scenario. So that's also something that you can assess, and maybe in your laboratory establish a protocol of only freezing grade 1 embryos for cleavage stage, and for blastocysts nothing less than 3 BB should generally be frozen. Now the last KPI that we want to assess is the successful biopsy rate, and this basically is the number of biopsies in which DNA has been detected and amplified divided by the total number of biopsies that have been done. Again, this is a good indicator of the skill of the embryologist, especially the skill of tubing of the embryologist. It sometimes might also tell us a little bit about the shipping conditions of the sample. Let's say the shipping conditions were not established properly. In those scenarios, the amplification rate might vary. It can also tell us about the quality of the genetic laboratory, and that's why if you're doing biopsies in your clinic, this is an important rate that you would want to consider measuring in your lab. Alright, so these were basically all the different indicators that we have for the laboratory. There are certain more indicators that can be assessed, and basically it could be in the form of day 5 clinical pregnancy rates, it could be day 5 usable blastocyst rates, cumulative clinical pregnancy rates, etc. But I mean, these are all additional key performance indicators apart from the list of 19 that I've already mentioned. If you want to start with measuring the performance of your laboratory, start with those 12 key performance indicators. If you're already doing those 12, then add those 2 reference indicators to measure the clinical side a bit. And if you're running a very busy lab, and also if you're running multiple laboratories, adding the whole list of 19 performance indicators for your laboratory or laboratories is absolutely beneficial. It will tell you a lot about your team, it will tell you a lot about the amount of embryologists that you're handling, also the clinicians that are there in the clinic, their techniques, their skill levels, their experiences, etc. Everything can be measured by these key performance indicators. And then the best part about this measurement is that you're not going to blame them, but you can train them to achieve the same amount of competency and standards that everyone else in the team is actually achieving, and also try and measure yourself up with international standards and then offer that to your patients. So this was just a brief description of key performance indicators. If you have any more questions, you're free to contact me on my email ID. I think that will be mentioned after this lecture. And hope you had a good learning experience with this lecture, and happy to answer your queries on email.